My name is Chris. I run the Nassau Mobile Crisis Team. This is Joe, and he's one of the social workers. Rob is one of our other social workers on the team. Currently, the team has 13 social workers. Since the police reform, we were expanded to 18. We're having some challenges filling those positions. The team is comprised of licensed clinicians and specially trained to go into the community to do psychiatric assessments to see, one, if someone needs to be seen in an emergency room. If they are not in need of being seen in an emergency room, we can help connect to OMH licensed clinics within the community. We can, this is in relation to Nassau County. I know you are both Queens and Nassau, and Queens, we're not really familiar with how they run with the different catchment areas. We cover the whole county of Nassau. So the team has been, I apologize, I'm jumping around. The Nassau County has had a mobile crisis team since 1985, yes. And since 1985, the team has been charged with reducing unnecessary emergency room visits and arrests. So we are a resource for currently the Nassau County Police Department. And I say it that way because there's 18 other police departments within the county that are private to certain towns or villages or cities. So we are collaborating with them in addition to the Communication Bureau, the 911 system, that if a call comes in through 911, they can reach out to us and direct connect to the team from somebody who's calling 911. The team is in from 8 a.m. until midnight, 7 days a week, 365 days a year. The team is accessed through the Nassau County helpline. So that's the first step of calling 516-227-8255, 227-TALK. During weekdays, the phone number is answered by county social workers. During the nights, weekends, and holidays, it's answered at Long Island Crisis Center with counselors that are there. They will ask, one of the flyers that is in the back is a two-sided flyer, and it's going to say on the one side, the information, if you need to call us, the information you're gonna be asked for, then by the helpline. The team will then call you back and get more information, more in depth of what you're looking for the team to come out and do, what the team is able to do, which within the Nassau County borders, we can assess mental health safety. We can offer a connection to mental health community services, and if necessary, facilitate an emergency room visit, whether or not the individual is willing to go. There are a couple members of the team that have an advanced designation that can temporarily remove someone's rights to have them transported. It does not get someone kept in a hospital.
What is temporarily?
For the transport.
So how do you relieve them of that response? You know,
under the mental hygiene law, section 9.58. Both Joe and I are non-medical commissioner designees. That means that we have advanced clinical knowledge and training, that when someone, not just someone who is saying, I want to kill myself or I want to kill somebody else, they don't have to say those words to be in need of being seen in an emergency room. So if they need to see a doctor and they say, I'm not going, we will fill out the legal documentation in addition to the assessment that we will send with them to the hospital in the ambulance. At that point, the police will take them in the ambulance. We do not transport. Depending on the area of Nassau County, if it's not a Nassau County precinct, it could be the Northwell ambulances. Who else transports now?
Right now, Northwell, and to our latest knowledge, NYU Langhorne does do some mental health transports, I believe, in Garden City with Garden City Police.
Why don't you take off your mask just so,
Oh,
because they
okay.
can't hear you.
I saw everybody, so I didn't want to.
Oh, no, we just can't hear you,
Okay,
sir.
that's not a problem. Sorry,
No.
yes. So yes, Northwell Ambulance does, like Rockville Center, a couple other towns, that's in flux, at least as far as we know. But NYU Langhorne does Garden City. So if we request a transport, then those are the two ambulances besides Nassau County Police ambulances that will respond and will transport anybody, that we deem.
So even though you know it's a psychiatric emergency, you don't go directly to Tucker Hillside or to South Oaks, you go to an emergency room.
Those-
South Oaks is non-emergency receiving,
But Sucker Hill or,
is Queens.
it's considered Queens too?
It is Queens.
Okay.
You're over the line into Queens. It's up to the, we don't determine the, destination of the transport. It depends on, cause the medic will then contact medical control to find out where the next place to go to. There's a lot of hospitals that go on diversion. So if they're on diversion, at that point, it'll be the next, psychiatric receiving emergency room.
Because obviously there are fewer psychiatric beds like Syosset,
Right.
no
Once
longer
somebody's
have a
in an
psych bed.
emergency room, they can be transferred to where the
Right.
bed is.
Got it.
It's
Like if we
about
were
getting them
somewhere-
there.
right, if we were somewhere and they needed to go, the closest emergency room for them to be evaluated psychiatrically was Syosset, they would go there, and then it would be up to Syosset to do the evaluation if they determine that.
I'm just saying
Yeah.
they close their psych beds.
Yeah,
I'm
they
just
did,
getting this.
but they can still evaluate and
Okay.
then just see what's in their system as far as where to transfer.
Okay.
That's the piece that we don't have a whole lot to say about. If someone is at the time of being transported violent, if they, I guess that's pretty much.
Yeah.
At that point, they would go to, Nassau University Medical Center,
Got it.
because it's a locked unit, a locked ER.
Yeah.
If we do encourage families that when we're there, if they want a specific hospital, ask the medic. It's always worth asking the medic, because they may be able to do that. So we are rapid response, we are not emergency response. So if it's something that needs an emergency response, we are always going to say, call 911. If you are not able to call 911, we'll call 911 for you. They're gonna be able to get there more quickly, because the patrol is in the neighborhood already. If we are in Farmingdale, getting to Glen Cove, depending on the time of day, could take over an hour. That safety always has to come first. So that's when we're calling back, you're talking to the second time. The first phone call that you make is going to get the information generated to the team, and then the team is gonna call you back. And the response time, again, we are 13 or 15 people covering 7 days a week, 16 hours a day, that there may be a day that it's only 1 or 2 people that are on that shift, and if they're on the other part of the county, it's gonna take a little bit longer to get back to you. So that's, typically, we can get to a location within 1 to 3 hours. So with that response, in an emergency, you need to call 911, because that's not something that, we wanna take a chance with. We are typically called out for a variety of mental health concerns, in addition to, if someone is exhibiting signs or symptoms of their diagnosis, maybe they're not diagnosed yet. We have seen as young as 4 all the way to 97. So we can see any age as long as they are within the county borders. And when I say within the county borders, the significance of that is that they do not have to be a Nassau County resident. If they do not live in this, say, your child's friend is coming home from college with them, and something happens and you need to call us, we're gonna come out and see that friend. We're not gonna connect them to services because they live in Michigan. They're not gonna show up. They can't show up, they don't live here. So we're gonna see if they need to see a doctor right away, and, then make that happen if it has to happen. Any general,
Do you have any connection with the 899?
988.
988.
988, I'm sorry. Do they ever refer people to you?
they have, the 988 is run through Long Island Crisis Center also. Long Island Crisis Center, has a number of, hotlines that go through them. And, they have called us, I'm trying to think, it's a couple of times at this point. They may refer to 911 with some of the calls that they're getting. The, so connection to services and general concerns about someone's functioning. It doesn't mean that somebody needs to, hospital or don't call. No, if there's a concern, we can come out. Some of the limitations are going to be if, I'm just trying to see what we had. If someone's currently at a clinic, if they're currently at their program, we can't go there. They have a medical team that's there, their psychiatrists, their primary doctors that are supposed to be doing that assessment. And if they're in need of going to an emergency room, they would then facilitate that from there. If someone is in relation to children, if they're in a residential treatment center, if they're in a residential treatment facility, again, they have the clinical team there that would do that. Skilled nursing facility, assisted living, and the reason these are on here, we've gotten calls. We've gotten calls from people that are in beds in a hospital for medical reasons that don't like what the discharge is gonna be and they want us to come. We can't. They already have the teams that are there to take care of that. In relation to children under 18 years old, a guardian or a parent has to be present in order for us to assess them. And one, the reason is that they're a minor. The significance of that under the, I can't remember what the law is, that the number of it basically, the parent or the guardian is protecting that child's rights. So they need to be present for that. And we can go to, I'll finish what we can't do. If someone is currently sitting in an emergency room, we've been called and asked to come to the emergency room. We can't do that. If someone is looking for assistance with their utilities, with heat, hot water, that's not something we're able to. We can give them phone numbers through when they're calling, but we can't go out and remediate that. If someone is currently intoxicated or under the influence of any substances, we can come out. It limits how we're gonna be able to assess. We can't do a full mental status assessment on someone who is currently under the influence. So we can come and check on safety. We can discuss their baseline. We can discuss what servicers are available, but again, services are going to be voluntary. So we can come out, it's just going to kind of limit what we're gonna be able to do. If there is an active shooter situation, that's not, unless hostage negotiation calls us to meet them there, we're not gonna respond to that scene. And from midnight to 8 a.m., the team is currently not staffed from those hours. Trying to think, what did I miss? Jump in.
Do you wanna talk about, a little about schools? In terms of children?
Yeah.
Okay. In terms of children, we do get calls from the schools asking us to come out. And as Chris said, they can call us, but there has to be a parent present in order for us to, finish any kind of assessment. If the child needs to go to an emergency room, they have to be present because the child is gonna have to be accompanied by the parent if that's a transport. If we're going to make a recommendation for a clinic for the child or other services, parent has to be there in order for that to take place, because the parent's gonna have to be the one who consents for all of the information. We do an assessment, and then if it's a referral, we'll send paperwork out, but again, the parent has to be there because they have to sign off on all the consents for any services that we do in the school. But we do get called from schools as well as, from parents in their homes.
The entire team is certified in nonviolent crisis intervention. So everyone is certified and re-upped every 2 years. So the team is not able to, because sometimes we will have families giving us a call for their child who, in addition to maybe some mental health concerns, is on the autism spectrum. We are not able to put our hands on anyone, and that we're not gonna be able to restrain anything like that. There is a team through OPWDD that is able to do that, but that's not something that we're able to do.
All right, so how about the things that we can do? So mobile crisis services, I'll give you a scenario. Let's say a client hasn't been taking care of their personal grooming for a week, the family's concerned. We can come to the residence, meet with the client, really just have a conversation with them, see where they're coming from like a strengths-based perspective. We try to empower the individuals to do things that would help better their own lives. And this could be in the context of connecting them to the services that may not have been available to them, or giving them resources that they didn't know were possible. Like, we could refer clients to clinics that are sanctioned by the Office of Mental Health in Nassau County. We can't refer to private clinics or practices or anything like that. We could provide clients with hotline numbers for the Bogle-Austein Crisis Center. You mentioned 988, right? That's the, it's great that that's now a national standard, because somebody in Nassau County gives that number a call and they do get funneled in through us. And what's great about the mobile crisis response process is that we have, the hotline workers that already are initial wealth of resources that can help people get the services they need. And if they need additional, more in-person interventions, that's where we come in. We do mental status assessments, which isn't like a full psycho examination. It's more like seeing how they're presenting at the time of the visit. If they present in a way that may be a harm to themselves or others, we're able to help initiate the transportation process, like we said, via 958, or just by speaking with them and letting them know, hey, from the things that you've told us, it seems like a hospital would be the best benefit for you to get the services you need. And and that sounds a little corny, but through a conversation, just like a normal face-to-face conversation, people they hear it from a trained mental health perspective, and they usually are more than willing to walk into the ambulance with us. What else do we do? Conflict resolution, suicide prevention. Well, we do assessments for suicide. We follow up with safety questions. We ask if they're self-harming, and we really not probe, but kind of just try to get into an engaging conversation about where the client is currently and their past history, emotionally and mentally. And from our conversation with the client, we make a decision. We could connect them to resources, or we could have them transported if need be. So ultimately, it boils down to really informative and intentional conversation with our clients, which leads to quality of care that it's good quality care.
One other thing that we do have access to is because we're in the building with social services, we can be in touch with Child Protective Services there in our building. We can be in touch with and make referrals to Adult Protective Services, because some of the times we get calls on someone who may be not necessarily hospitalizable, but their situation may be that they do need assistance with housekeeping, with finances. So that's one of the things that we can tap into because of where we are. And we do a lot of interaction with Adult Protective Services and with Child Protective Services. We're also in the same building with the Department of Mental Health for Nassau County. So we can have conversations with them about care coordination. We refer a lot of families to them, give them the phone numbers, someone who needs that extra help. So that's another thing that we're able to connect to because of where we are in in the building.
So many people have a problem getting to the first entry point and just getting a care coordinator and just getting into the quote-unquote system, because let's say their loved one is, on the younger side and it's their first episodes, they're still on their parents' insurance, now they're want to get onto Medicaid and start going to and receive the services. So that entry point is full of confusion, and where do I start, and which website? If you go to the .gov website, you're just never going to find anything. So is it appropriate to call you guys for that entry point information?
It can be. There are a certain number of programs through the county that are grant programs now, and one of them is pretty close to immediate response, that if we make a referral to them, it's within a couple days.
Wow.
And the glitch with it, or the hitch, is more that they also have to want a therapist, because then they can
That's
also
a
get the
problem.
care coordinator with that. It's unfortunately, we used to be able to get people into things within a day or two, but since COVID, that it's more difficult. We are looked at as one step below an emergency, hospital discharge. So it will get brought up. There are a number of agencies that are under a federal grant now for, it's CCBHC, it's Comprehensive Community-Based Health Center, I think is what it stands for. They have the care coordination services, so we can also make a referral to those agencies as well. So
you can
it's-
funnel it, you can try to figure out.
and we can, that's exactly what we can do, we can help try to figure it out. As long as the individual is looking for the services, we're not carrying caseloads, so we're kind of one and done, but we want to make sure you're connected. So we have a lot of freedom that maybe a clinic wouldn't necessarily have, and we have a lot of access to all the services within the county.
What's the difference between mobile crisis and an ACT team?
An ACT team is gonna be ongoing services that'll come to you. Your therapist, your prescriber, case manager, all from, I believe it will be through one agency, it's a whole team. We're mobile crisis, we don't have any caseloads. We can see anyone in the county, we are a free service. And we're pretty much one visit, and then if we're connecting, we'll make sure that the connection happens. If we're connecting you to something, there's no limit in how many times we can be called. So it's,
Thank you.
I don't wanna put you on the spot, so if you can't answer, say I can't answer. I had mentioned that we have a pretty active advocacy group. Is the reason that you don't offer services after midnight a financial reason?
when we were doing the, before the police reform was sent up to Albany, we had a work group. And when the numbers were pulled, we got the expansion of anticipation of more referrals coming to us. And when the numbers were done, there were not enough during those hours to warrant full-time staff.
Funny, naively, I thought there would be more in the middle of the night than fewer in the middle of the night. But the reason I asked, if it would be successful, we could talk to our county legislators and see if they would add money, for nighttime.
Let's talk as soon as we hit 18.
Okay.
Because we under Office of Mental Health, we track everything in relation to demographics, volume, frequency, things like that, not in relation to people's names, just where we're going and stuff like that. Once we hit 18, the goal is to ask for more. But until we have 18 people, we're limited.
I'm surprised, as I said, I would have thought nighttime would be very dangerous.
They pulled the numbers from the 911 data. So that would have been, I believe, the 2019 numbers of the calls coming into 911. So that's what we were going off of.
Okay, thank you. Okay, does anyone have any questions? I just want to explain something, so the people who are here from Queens, we called Nassau, and with a date, we got a response from you.
Oh, I'm glad.
We called Queens, and we're still waiting for a response. So, to be fair, we wanted to have both counties represented. But, and I called, Queens several times. As a matter of fact, I recorded things in the recording line, and we still haven't heard from them. So thank you so much for.
Oh, absolutely, thank you for inviting us.
So I have questions. In terms of your, have you noticed an increase in demand of your services? Are you being called more frequently now? I mean, in theory, most mental health providers are maxed out in a lot of ways, private ones. But anyway, have you seen a tremendous increase in the calls for you?
We've had an increase, but we also are, we're again, as we're tracking, we have officers calling us from scenes that they're at, which is definitely an increase. We have an increase in people that have long-term mental health issues, that we're seeing more of that demographic has increased. I'm trying to think. I don't know if we're getting as many referrals for, or not, I don't think it's increased of people that have no services at all.
Do you guys do any advertising yourself to tell the world that you exist? Because you're still a big secret on many levels.
We've gone out to every police precinct, because they're gonna have the most interaction with the public. Anybody that asks us to come out,
Yeah,
we're
no,
gonna
I
come
know.
out
I'm
to.
not blaming you guys.
No,
I'm
no,
just
no, I'm
like,
trying to
when I
think
bring
that
it
I
up,
don't know.
people are like, what are you talking
I
about?
know.
We're willing to.
So,
come
I
by.
mean, we did call, so there's a little bit of confusion on my part too, in terms of, so Life Crisis Center versus, like, what is the name or?
Nassau Mobile Crisis Team. So
Nassau
we are
Mobile-
the only mobile crisis team in Nassau County.
So what is the Life Crisis Center? You're not
No
associated,
idea.
no would
Not
feed
associated.
into it at all, okie dokie. So,
Yeah.
mobile crisis, so do you have any social media? Do you have any kind of outreach?
I don't think
Right
so.
now.
Yeah,
Yeah, I don't
because we
think so.
tried, I don't know if Jade is here or not, we, our social media person, as we were trying to get more traction for the meeting, there was, all right, everybody, please don't laugh at me, but there was confusion for some people who we asked about children in crisis, because that's what we were kind of tagging this because of the fentanyl presentation. And people really thought that I was talking about children with crisis with phones, with mobile phones. So, I mean, it just, the world and the nomenclature, like, you wonder sometimes, we shouldn't rebrand you. But it just, trying to get the messaging out. So social media, so we called and we tried to see if you guys had any social media platforms, and the answer, I guess, was no. So we could retag, so we could spread the word,
I know they had done some stuff on the buses for Nassau County about the hotline, because everything runs through the mental health hotline. If you call them, they're gonna.
So the mental health hotline, the 424-TALK or whatever that
No,
is.
227 talk. Oh, I think.
No, I'm
yes,
sorry,
yes,
yeah,
yes.
yeah.
That
Talk,
number, yes.
I mean, we have that on our site and so forth. So it's the, okay, let me re-articulate. So to get to mobile crisis, you're gonna get to it via that
That number.
talk number. And that is branded as what?
It's the Nassau County Helpline.
Nassau County Helpline. Again, not
For
defining
anything.
mental health. It's help for anything or help for mental health?
It can be help for anything, because if someone's looking for housing, if someone needs to be accessing public assistance, things like that, it's gonna be the way to get the phone number, get the connection. That's the number to call if there's questions,
Okay.
because they're gonna, the social workers that answer that have binders about that thick of all of the resources.
Again, just asking, so you
Yeah.
interact with social workers at hospitals and so forth, so
Not
they
really.
know who you are?
They should. We're usually on their discharge plans.
Okay.
I'm trying to think, the county's annual conference, that information is given out then.
Oh, don't even go there. Do you know what they distribute? It's like 10-year-old information. It's ridiculous. It's not
At this, unfortunately, because since 1985, because a mobile crisis team is a specific entity. It's not just something that was picked to name it. that it's under a specific, it means something.
Okay, I
That
get
it
it.
means that we'll collaborate with the police, it means we're gonna collaborate with other
Okay.
resources, that it's, and it also enables the team to have the 958 designate.
Well, like Chris said, this team has been in operation
I
since
know,
1985.
I know about you guys, but when I bring it up,
Yeah.
People
Nobody
don't,
else
No,
does.
I know people don't know. And I've been here since 1985.
Yeah.
And I get that all the time, that people don't know. I mean, stuff we're doing today, you know, we are working more with the police are calling us. So, like a lot of stuff, it's a process, and it doesn't always go as smoothly as we'd like. But
Right.
we are here, we're trying to do these kinds of things, just to let people know that we are here.
I've been
Yeah.
here for a year and a half, and it's definitely jumped a little bit in regards to community engagement. Like the billboards on the bus have been helping. 988 has been useful as well because people are now funneling towards us more. And, oh, I'm sorry. So sorry. So while we don't have a social media presence, the use of the buses has been helpful. The 988 accessibility has been useful as well. So while it wouldn't be as impactful as say social media, people are slowly getting the word or hearing of the mobile crisis team. Also, another big help has been really when the police call us on scene to meet with them, and like more consistent interactions with the police have been leading to different conversations in regards to like what we do. And then one officer tells another officer, and then we show up at another call, and then we slowly but surely are getting more utilized.
so you've been CIT trained, but you do not do CIT training, correct?
I can only train the team, or within, we're under an agency that's contracted to the county,
Okay.
and it's under CPI, Crisis Prevention Institute, that the team is certified under, and under that, instructor guidelines, I can only train within
Okay.
the
Interesting.
agency.
Just to clarify, so if I have a family member and I notice that they're acting differently, maybe I notice that they're not actually taking their medication.
Thank you.
Hello, okay. So if I have a family member and I notice that they're maybe, acting differently, they're staying in their room and they won't come out, or I notice that they're not actually taking their medication, it would be appropriate to call you guys to have a meeting with that person and go over the situation and what's going on, right?
Sure.
Like absolutely, because it's an abnormal change in their behavior and it's concerning. And if they're not med compliant or if they're just feeling more depressed than usual, we always go out and see what's going on.
That can prevent, like a police call.
Yeah.
Well, typically, what are children taught from kindergarten up? In an emergency, what do you dial? 911. So that's gonna be where people are gonna call, which the collaboration with the 911 operators is helpful, because they're gonna be another route to reach us. They have a direct number to get us while they're on the phone with someone.
It's also nice that I can call when I start to notice it, and I don't have to wait for that big dramatic event to
Exactly.
happen.
You don't,
have to
no.
wait for the
That's
blow
it.
up.
Nope.
Is there
We
a
would
question
like
in
to
the
get
back?
there before that,
Exactly.
That's the
then
one.
we can convince that
And we'll
person.
work with that.
Because
988, yeah. Thank you.
Okay, so 988 will redirect you to us. That's kind of like what the national initiative has been. So, you know,
No, it's another access point that well, indirectly to us.
Yep.
It's
So
not gonna
another way to
be,
get to us.
it's not a direct connection.
It's not gonna do more or less than the future, it's doing the same people.
Yep, you call them and then let them know what's going on and they'll help you get towards us. It's kind of
Or you directly, if you.
Right.
Yes.
exactly.
Yeah.
So their number is on NAMI-QN's website. So if you click crisis and scroll up, you see the different mobile crisis for Nassau, Suffolk, and Queens. is on our site under crisis.
Yeah, I just wanted to say that, when my daughter was going through an episode, I called the mobile crisis line, and I think this gentleman right here came, and, I didn't want her to go to the hospital at all, but I knew she had to be assessed, and you assessed her, and you told me she had to go to the hospital. And I sort of was not sure whether I wanted, and you said, you know, I'm gonna call not legally, you said, I'm gonna have to call CPR services if you don't send her, because she's that bad, and it was the right call, so thank you. You really-
We are not looking to, when we talk about taking away somebody's rights, when I say we're tracking data, when I say we're tracking data in regards to removing somebody's rights, if we have 1,600 referrals, we're talking about 100 people in that year that would be having their rights removed. The goal is to stabilize and put the support in place so someone can stay at home. So if it gets to the point that we're saying somebody has to go, we've exhausted everything that we can think of. Because people don't get better in the hospital, they get stabilized and sent home. They're not gonna, that trauma has to be worth, yeah, that there's no other choice. Right here.
I don't know, there's one here, then you.
I don't think I need to back out. Is there any minority representation on your team? And if not, is there any doing any recruitment for minorities?
So we do have minority representation. We have me included, like we have a couple partners that speak Spanish. We have one mobile crisis team member who speaks, I think, Hindi or Sanskrit. I forget.
She speaks 2 languages.
She
I'm not
speaks 2
sure.
languages. We have somebody who speaks ASL. We have a couple. We have a diverse team. We're always willing and receptive to keeping it more diverse.
Do you have any African Americans?
Yep.
We do, yes.
Okay.
And what's really important about the representation in our team is that there is a cultural awareness that I've seen firsthand on scene that has been impactful in regards to cultural norms and expectations. So it's nice.
Yeah.
Always receptive. The more diverse, the better. We have to represent the county, you know?
Right,
And
we-
our county is very
we're
diverse.
servicing.
Yeah,
Absolutely.
exactly. Do you want a microphone?
Yeah.
Sorry.
Do you service people who have a dual diagnosis? Like, what would happen if someone has substance use issue and mental health? What would be the protocol?
We're gonna ask as much information, as much history, so that when we're coming there, we know which way to kind of point the direction in. If somebody's connected with services, we're gonna make sure that they are gonna go to the next appointment. We're gonna ask you to sign a release of information so we can contact them and say, we came out, let us know if they show up. We are not able to, any substance program that's strictly substance has to be a voluntary referral by the person, that they have to make the phone call. If somebody wants support in making the phone call, we can be there while they call. But we cannot make that call. I am pretty sure, if it hasn't happened yet, it's going to be happening, that mental health agencies are going to be required to have a substance piece to it, because it's co-occurring. So it limits when we're coming out, if somebody is currently high, if they are currently intoxicated, it's going to be more difficult to be able to go through a full assessment. But if they are at risk of safety-wise while they are under the influence, they're going to probably need to go to the hospital. I can think of an individual who was high on multiple substances who was trying to direct air traffic in the middle of a main road. He had to go to the hospital. I don't know what he took. I don't know if that was the only thing that was going on. But at that point, a doctor had to look. We do not have doctors on the team. So that's where that threshold is, that if a doctor needs to take a look, And it's not an admission to the hospital necessarily. Typically, if we're sending someone, they are getting admitted unless they are under the influence when they get through the ER doors. Because again, we're trying to stabilize where they are instead of reconnecting, things like that. And also in regards to if there's other services in the county, like a family member is getting repeatedly admitted to the hospital, we can then help connect to the county court-based mental health services of possibly getting court-ordered medication.
That's
So-
awesome that you could play that role. That's amazing.
And we try to walk, because literally they're in the room with us, that we walk over and say, hey, we just went out and saw this person, the family's calling you.
So it's amazing.
So we have time for like one or two more questions.
I have another question.
Sure.
If someone.
Okay.
In terms of transporting someone who is flailing or doesn't want to go, is there a procedure or policy?
It would be between the police and the medic
Okay.
that would determine that.
So-
Because we're not doing any of the transport. We're present.
Right. Right.
So I can give you an example. We had a client who was increasingly verbally aggressive. Every step of the process, we would talk to them, see how they're doing, and every time they became more agitated. When it came to transportation, since we had to take care of our immediate safety, the client had to go on the ambulance in handcuffs. Sometimes that happens due to, we go from least to most restrictive. Like, I mean, obviously we don't handcuff anyone. It's a conversation with the people on scene, with the officers, the client, and us. So if somebody needs to be restrained, it happens. If somebody's agitated at first, we talk with them for a couple minutes. They usually, once they feel heard, they feel seen, they walk onto the ambulance. So every call is unique, but we try to be as consistent as possible.
Yeah, I live here in Queens, in Jamaica, but my son is actually now finally getting the right treatment that he needs. And we had an episode last year where I had to call the cops and he was going to drop a second floor window, and that's how bad it was that I had to call 911, and then they sent me the services, and yes, so that was the case where he had to be handcuffed going to inside the ambulance because he was a danger to himself, he was a danger to the EMTs, and unfortunately had to go through that process, and then he was sent, he came here to the hospital, then from there he was transferred all the way out in Long Island. For my experience, I just wish that the hospital where he was at, they would talk to the parents more.
Yeah.
Because I didn't get that. I was actually excluded from even knowing if he was really out there hospitalized, because they wouldn't give me any information. If it wasn't for the emergency room here who told me, no, he's in an ambulance, he's heading out now, he's going to spend a few days there until he's stabilized, I wouldn't know. And that was, as a parent, that's frightening, more than seeing him put in an ambulance, because I know he was being taken care of as he was taken from the house, coming here to the hospital. But from there, being an institution for a whole week and me not being able to know anything, because he's now an adult, a young adult at 21, and that was, I wish no one could go through that.
But we all do.
Finally,
It happens every day, 100
Yes.
times a day.
yes, and now we're able to come here, he's been stabilized. I had to put him in a institution out of the country actually to get him to get medicated, because here I couldn't. As that age, I cannot force him to do anything he doesn't want, but as someone who has a mental health issue like he has, I didn't know what else to do.
So when they talked about AOT, an assistant, that's the, what you have to do in the United States.
Yes.
The other thing I would want to, that I think about when you mention that, one of the things we try to be aware of is when we're gonna send somebody to the hospital, we're doing two things. We do a handoff verbally to whatever emergency room that person is going. So they've got not only our paperwork, if it's an involuntary transport, but we're also touching base with them. The other thing is, we always give the family the contact number of whatever emergency room, because in my experience, a lot of times that doesn't get given to the family for myriad of reasons. But that's something we try to be really on top of. If we're sending your family member, here's the hospital, here's the emergency room, call them within a half an hour. Let them know what's going on so that they know not only from our paperwork, but from the family's perspective about what's been going on. So that's something that we try to be very much aware of.
If anyone, we're throwing a lot of information out there. If you have any questions, if you're talking to somebody and they have questions, please reach out through the helpline. And, you just let them know that you want someone from the team to call you back to kind of go over some stuff. That, again, we're in 8 a.m. until midnight. We can't always necessarily, if we're on a visit, and we are in person out in the community. We are not, unless there is COVID in the home, we're coming to the home. It is not telehealth, it is not a phone call, we are coming there. So that, I had forgotten to kind of point that out, because there's so many things right now that are not in person. But, we thank you.
I have one more quick question, I'm sorry, that I came late. If someone is acting erratic, in the street, you get a phone call, an anonymous phone call, does the crisis team come with a police officer in that instance, or?
Probably for safety. For safety of the person as well as the team. Because not knowing what necessarily is going on, and the, as long as we have an address, what we would do is, if we're the ones initiating the call to the police, we'd get to the location, maybe a block down, call the precinct and say, can you come out and meet us? We need your assistance in assessing someone.
Do the police ever call you?
Mm-hmm.
Yeah.
Yeah.
All the time.
Okay.
More often every day.
It's
actually.
become much more frequent that we're in collaboration with
Very
them,
nice.
so.
Yeah. Okay.
Thank
Thank you.
Thank
Thank you for your patience.
We apologize that as many people signed up didn't come, but this was very helpful
Let us know.
We just want to thank you for coming, and a NAMI bag and a certificate. Thank you so much.
Thank you so much. Thank you for asking us.
Oh, my pleasure. I'll
Thank you.
speak to you about that.
Absolutely.
David.
You go back.
Okay, you can't pick up the newspaper, you can't watch TV, you can't listen to the radio without hearing about the fentanyl crisis. What concerns me is now that marijuana is being legalized in New York State, some things that should be legal may not be legal, and people who are taking drugs may be taking fentanyl when they do it. So it's our pleasure to introduce Detective Lieutenant Matt Landman, and he will talk about the fentanyl crisis. And I think you're in for a treat. Liz saw him at his last, and she highly recommended. So thank you for waiting. Thank you.
Yeah, Matt's presentation was so disturbing, I decided that more people needed to see this presentation.
More people need to read the story.
Yeah, more people needed to really understand the incredible camouflaging of these pills, so,
Okay.
thank you.
Can everybody hear me without the microphone? Because I prefer to not use the microphone. Can you hear me okay, dear? I'm sorry? You'd rather me use it, okay. All right, well, my name is Matt Landman. I'm a detective lieutenant with the police department. I run the narcotics unit. I've been running it for the last 3 years. I've been with the police department for about 17. I've worked all over the place. But I really enjoy this work. I've been doing it since I've been a cop. And we'll just kind of get to it. There is a drug death crisis in the United States. So there's an overdose crisis. I like to differentiate a little bit because I look at the overdose crisis as a problem where, let's say, people are dying because they make the active choice to use drugs on a regular basis. So as far as in regards to the drug death crisis, where someone is maybe trying something for the first time, they're not an addict per se, and they're just, dabbling or socially using, and they think they're taking one thing and they end up taking something else and it kills them. So I like to differentiate that a little bit. Okay, so these are statistics from 1999 through 2020 of all the drug deaths in the United States. I couldn't find the chart with 2021 in it, but in 2021, it surpassed 6 figures. It was almost 108,000. So 108,000 people died from illicit drug deaths in 2021. That's roughly a 747 crashing every day. It's that amount of people dying because of drugs. This next slide is pretty similar. Okay, so this is the one we were looking at. This next slide, this is just opioid deaths. So you can see this is the total deaths. You see the next slide, very similar nature, but a little bit lower. So this is the amount of deaths that's attributed to just opioids. Last year there were about 2021 there were about 80,000 opioid deaths. So these are those numbers. The left column is the total deaths. The middle column is the opioid deaths. The right is the percentage, opioid to total deaths. So it's roughly over in the entire country. It's roughly 3/4. So these are Nassau County numbers. These are from the Nassau County Medical Examiner's Office. Obviously, the left column is the year. The next column is the opioid deaths. The next column is of those opioid deaths which are attributed to fentanyl, and the right column is the percentage. So mind you, in the 2022 numbers, that is only through September. So that is only 3/4 of the year. You can see the numbers are going up, so roughly 90% of all the drug deaths in the country, in the county, are due to fentanyl. So it's higher here than it is countrywide. Put those numbers in perspective, last year there were just with the opioid deaths, there were 80,000 opioid deaths. That's more than everybody that was killed in a motor vehicle crash or an intentional gun homicide. And I don't usually even read the bottom two because usually I talk to high school students that aren't really aware of it, but it's more than all the Americans that were killed in the entirety of Vietnam and more than everybody that was killed in the worst year of the AIDS crisis in 1995. So what does the police department do? It's a multi-pronged approach. Each prong has its importance. Can't really do it with one prong alone. I think hands down that education and awareness is the most important prong because as you'll see as I go on, the problem's not going away. So I really feel personally and professionally that the only way is to really educate the youth and stop them from becoming addicted and when using drugs at all. People might think it's counterintuitive. Enforcement, that's what my unit does. Enforcement's not as important as education is because if you lock up a drug dealer, besides the fact that in New York State he's getting out the next day, if he did get locked up, get sent away to jail, some other drug dealer would just take that place. Diversion, that's through the court system where someone gets into trouble with a minor drug offense for the first time, they'll send them to diversion court as opposed to criminal court. They'll have to go through some testing, dole testing and certain programs and whatnot, and if they don't follow through, they give them several strikes, but if they don't follow through, they'll send them back to criminal court. Treatment, obviously there are tons of treatment services available out there. While the department doesn't offer them, we do hand out pamphlets which show everybody, the services that are available. Something like the 227 Talk, well, that's a phone number that you can go to. There's Nassau County has the website where you click on the link and it shows you all the services that are available. And then aftercare visits, my unit responds on every overdose that occurs in the county, and we do follow up with them in the following weeks and again, offer the services, see if there's anything we do to help. Unfortunately, they're not very successful. Most people don't want to talk to us and are bothered by the fact that we ruined their high, even though we saved their lives. So what drugs and paraphernalia out there? I usually go through this pretty quick because this really isn't the meat of my presentation. These are the drugs that are out there and that are regularly available in Nassau County. There's cocaine, crack cocaine, there's heroin, there are party drugs like Molly and ecstasy, crystal meth, which is thankfully not a major issue here, single-handedly destroys communities in a very short period of time. And then of course there are prescription pills. So like I said, this presentation is predominantly geared towards, I presented high schools, I 9th through 12th graders. So a lot of this stuff, this is what I deal with them. I typically do talk different to parents, but I'll go through my presentation, I'll throw some other stuff in. These are the faces of chronic users before and after pictures. So these are arrest photos. This is before they use drugs, and then both of these girls, it happens to be 4 years of chronic drug use. The left is 2 years, and the right, that's just 1 year. All of these are available on the internet except for this next slide. This was an actual Nassau County resident. I worked with someone who knew him. He was an athlete, he got hurt. He was prescribed a prescription pill, painkiller that was far too strong. Prescription ran out, he was addicted. So he went to the street for pills, couldn't keep up the habit, so he switched to heroin. Now as you can see, I mean, this took quite some time, 18 years, but it's the same person in all three pictures. He died shortly after the last picture. This gentleman was the same path. He was an athlete, got hurt, pills, went to the street for pills, switched to heroin because it was cheaper, and turned into the shell of the man that he was. Do believe he survived. So I always tell the students to take note of the faces, and why they look like that. I've probably given 50 lectures, and I've only had one person ask me one time. One girl asked why their faces look like that. So I started, my presentation morphs and I add things as it goes along. So I added this in. So why do their faces look like that? So it all comes down to, obviously, what the drugs do to the brain. And it comes down to dopamine. So everybody's heard of dopamine, but dopamine is the feel-good neurotransmitter that's released in the reward center of our brain. So things we like. I always tell the kids, you know, you come home from school and you open the door and the fresh smell of mom's chocolate chip cookies hits you. Okay, dopamine gets released because you know you're about to eat that chocolate chip cookie that you love, or banana bread, or whatever favorite meal. Whenever you eat ice cream, or you know, a little retail therapy makes us feel good. Today, sex releases dopamine. Unfortunately, in today's day and age, anything social media related, likes on the, it releases dopamine. The kids feel good. But this is, so it all comes down to what the drugs do in the dopamine in your brain. And when it comes to drugs, we call it chasing the dragon. So when it comes to, this is really when it comes to opioids. So the elusive pursuit of a high equal to the user's first, the use of a drug, which after acclimation is no longer achievable. So very simple terms, the first time someone uses a very powerful opioid, it sends the dopamine level in their brain so high, it's the best high they've ever gotten in their lives, and it'll never ever get that high ever again, ever. It's chemically impossible. So the first time, let's say someone uses heroin or fentanyl and it doesn't kill them, the dopamine level will go higher than it's ever been and higher than it ever will be, and they will spend the rest of their lives trying to obtain the same high. So one bag of heroin turns into 2, turns into 5, turns into 10 bags a day, because they're trying to use more drug to get higher or get right on the cusp of that, of living and dying. So that overdose where they're, you know, that's what they're trying to do, to try and achieve that high, and that'll never happen. So I was at a panel recently, a few months ago, and there were addiction specialists there, and one of them was a former addict, and she explained to me how she was found near dead in a bathroom with a needle in her neck. And she was revived, and she spent the next year and a half, she called it chasing the bag. So she spent a year and a half of her life running around the city she was in, trying to find the stamp, the bags with the same stamp that nearly killed her. So there is hope. There are those services out there. These are recovered. But this is reverse. This is the left picture is when these girls were on drugs, and the right photo is once they've moved into recovery. Same thing with this slide. Left photo is while using, and the right photo is on recovery. Anybody that's never seen it, this is the Addict's Diary, is an online blog. There are dozens of stories on there. People give intimate details of what happened to them. Most of these people live very difficult lives, as anybody that's involved with addiction knows. It's an everyday battle. And I explain these to the students that it only takes one slip up to go from the right picture back to the left. And the only thing I can suggest is never get involved. So, and then in comes fentanyl. It's completely changed the drug game. Deadliest drug our country's ever seen. Worse than crack, worse than heroin, worse than meth and pills. And it's virtually in everything nowadays. So what is it besides this chemical compound? It all starts with the opium poppy plant. So it's broken down into three things. There's opiates, there's semi-synthetic opioids, and fully synthetic opioids. So opiates are naturally occurring substances in this plant. The stem, the leaves, the seeds, they are things that are physically extracted directly from the plant. Then there are semi-synthetic opioids, which you take those opiates and they're slightly processed in the lab and create things that we all know, like prescription painkillers. And then fully synthetic opioids have absolutely nothing to do with the poppy plant. They're totally made in a lab, man-made. So these are examples of opiates, morphine and codeine. They've been around for a very long time. Extracted directly from the plant. Semi-synthetic opioids, like I said, you take these opiates, you brought into a lab, they make Percocet, Vicodin, any prescription painkillers. And I always ask, anybody's ever heard of Tylenol, right? Okay, well the real drug name for Tylenol is acetaminophen. So it's a brand name, Tylenol. So the same thing with heroin. Heroin's a brand name. So diacetylmorphine was first synthesized in the mid-1800s, and it was then mass-produced in around 1898 by a German drug company called Bayer. So tuberculosis was rampant back then, and they synthesized this, and codeine is found in cough syrup, so it's naturally a respiratory suppressant. So morphine properties are very similar. So they took morphine, they processed it, they synthesized it into diacetylmorphine. So they created this elixir, it came in little vials like this, and they gave it to people. They tried it out, and instead of being hospitalized or bedridden because of the tuberculosis, they were able to carry on normal lives and go to work and be productive. So they were creating everyday heroes, and heroin is the German word for hero. So they branded it that, and it's stuck to this day. And the heroin today that everybody sees and thinks of is someone down some alley with a needle in their arm. It's a very far cry from this traditional, or I should say original, medicinal use that it was created for. Then we move into fully synthetic opioids, like fentanyl. Man-made, much cheaper. You don't have to worry about a bad poppy crop in Afghanistan or wherever. Far more potent, far more profitable. One dose can cause death. And it's found mixed in all the drugs that I mentioned earlier. So again, it is easier to make and acquire, easier to ship and smuggle, far more potent, far more profitable. This vial here is the amount of heroin that could kill the average person. This is the amount of fentanyl that could kill the average person. And this little speck right there is the amount of carfentanil that could kill the average person. Carfentanil is 100 times stronger than fentanyl. So fentanyl is 40 to 100 times stronger than morphine or heroin. Carfentanil is 100 times stronger than fentanyl is. We don't really see it, but it is out there. So this picture on the left, that is a seizure of heroin. Let's just call it 50 kilos. Okay, where his hand is, I've zoomed in on the right. Let's just call that 1 kilo of fentanyl. That 1 kilo of fentanyl is worth that entire table of heroin. That's how profitable it is. It's dirt cheap to make, costs way less than a kilo of heroin does, but it's so powerful and so potent that it can be mixed with a table full of cutting agent and create that much product. That's why this problem's not going away. And that 1 kilo is roughly 1 million street doses, but I think that's on the low side. This is a seizure out in Alameda, California, about 9 months ago, back in last April. All fentanyl, all different colors, pink, blue, purple, green, yellow, orange, everything. It's passed off as all different types of drugs. And then fast forward to August of last year, the DEA put out this notification about brightly colored pills being peddled to young adults, young Americans. Okay. These pills are stamped to look like the blue M30 oxycodone pill. Okay. It only comes in blue. So why anyone would want to take one of these fake pills knowing that it's not real, I don't know. But I think it's a calling card saying that they're not real, but then again, why would anybody want to take it? We'll just skip the 2 milligrams of lethal dose of fentanyl. That's it next to a penny. The next slide's a little bit better. That is 2 milligrams of fentanyl on a penny. And then mentioned carfentanil is 100 times stronger. So that's 20 micrograms of carfentanil versus 2,000 micrograms of fentanyl. That one little speck. Like I said, we don't really see it, but it is out there. So just to put that amount in perspective, everybody knows a packet of sugar. We all go to the diner and you see packets of sugar. Okay, so a packet of sugar is a gram. It's 1,000 milligrams. So simple math. Packet of sugar's worth of fentanyl has the ability to kill 500 people in 2 milligram doses. So this is the last slide, last chart. This is illicit drug deaths from 1979 through present day. It's very linear, which means it stays in a line. There's little blips along the way. Always tends to correct itself. So, for instance, right here, 2006, right there. That's when black tar heroin came into the United States. People didn't really know how to use it. They were using it the same as powdered heroin. So a bunch of people died. Then they figured out how to be used a little differently. So the line corrected itself. You got this little blip right here. It's 2011-ish. It's when hospital workers realized they could take fentanyl patches off of patients in the hospital and there would still be fentanyl in there. They would take a bunch of patches home, put it in a pot with a little water, boil it down, and they would inject themselves with the product that was left. Obviously, there's no possible way to properly dose that, so some people died. And we get to this point right here. This is 2013, 2015. It's when China started pumping fentanyl into our economy. And obviously, there's a clear divergence. So this green line is where we should be, based on the linearity, whatever you want to call it. The red line is where we are. So all these deaths up here are attributed to fentanyl. So it spiked. There was a drop. This is due to pumping out Narcan and Narcan becoming more available, ready available. And then after COVID happened, and Narcan it is harm reduction, but there's different ways of looking at it. I'll give you an example. In 2000, this is my first full year in narcotics. I got there in 2019. There was one resident in Nassau County who overdosed, documented, that we're aware of 30 times. 30 times. Every time we went, there was a draw full of Narcan, lived with grandma and grandpa. Grandparents always would issue with Narcan. Unfortunately, with someone like that, there's not much that we can do. We offered services, he went away to rehab, and then he did suffer from a fatal overdose in 2021. So he lived an extra year and a half, once he really became addicted due to Narcan. So it's harm reduction, although people look at it, some people look at it a little bit differently. Ultimately, you get a dose of fentanyl that's powerful enough that Narcan's not going to work. I'll discuss that a little bit more later. But yeah, so COVID happened, and then there was an even bigger spike. So I was at another presentation, a different CASA meeting, and the doctor came up and spoke and said, prior to COVID, 70% of overdoses were witnessed. So people typically do drugs together. When people started sheltering or whatever you want to call it, everybody was by themselves. Nobody heard the thud, nobody heard the labored breathing or the snoring, so obviously I think that contributed to it, but obviously you can see where the overdoses are now. It hasn't really slowed, and we've kind of gotten back to normal. So, 2018, Donald Trump banned China from producing fentanyl, and they did. They stopped. Unintended consequence of that is so now it's not produced here, it's produced here. So China doesn't produce it anymore, but they send the precursors, the vital ingredients used to make the drugs, to Mexico. So now it's manufactured at our southern border, not an ocean away. So Mexico took up all the manufacturing in 2018. It's no longer made by scientists, it's made by drug traffickers and clandestine labs, and they are businessmen. So they made the decision, because at the time, the most popular pill was the blue 30 milligram oxycodone pill. So instead of peddling the fentanyl to 3 to 4 million heroin users as stronger heroin, they figured, hey, let's turn these into pills, press it into pills, and sell it to, 25 million pill users. So with one stroke, they multiplied their consumer base by 600%. So these pills, they're increasingly lethal. You'll see I have slides further that show the statistics on how many of them have the lethal dose in them. This is seizures from the DEA Phoenix field office alone. This kind of lines up with when Mexico taking up the production. You can see that there really weren't many fake pills seized. 2018, about 400,000, then 1.4 million, then 6 million, 12 million. I think there were actually, this is very low. I think there was like 20-something million pills seized in 21, and there was even more seized last year. So the pills are probably the biggest problem we're facing now. One pill can kill. It's really all it takes. This is old. There is a new one right after this, but as of a few months ago, the DEA lab was saying that 40%, so 4 out of 10 pills that they tested for fentanyl had the lethal dose or higher. Okay, they're not laced, the pills are not laced, they're just fake prescription pills. They're made to look just like legitimate pills. They're increasingly lethal, they're widely available, they're everywhere. Basically, virtually every pill, like the blue M30 oxycodone pill and Xanax, basically every pill that we seize is fake. So I always tell the students, I said, like whenever we arrest a drug dealer, we'll have a fatal overdose, a person's phone will be open, we'll see the communication between the dealer, and it'll say, hey, they're fire, they're strong, only take half, be careful. No one's fooling anybody. The person selling them knows they're fake, the person taking them knows they're fake, but they went ahead and used it anyway. Okay, so let's say you're gonna listen to them, it's strong, so you're only gonna take half. How do you know which half that little speck's in? Is it mixed up evenly so that if you break it in half and there's a lethal dose in it, you get half the lethal dose in one and half the lethal dose in the other half? No, it's not gonna be like that. So a few months ago, they put this out, now it's up to 60%. 6 out of 10 pills have the lethal dose in it that they're testing. So this is the anatomy of how it works. Whenever we execute a search warrant and arrest a drug dealer, we always find a bullet blender, because every drug dealer, they get their drugs, and then they want to turn their drugs like this into this. So they mix it with cutting agent to make it so keep some for themselves or just make more money on the product they have. Larger drug dealers, it's done on a larger scale. Smaller drug dealers, done on a smaller scale. So we're just going to go with local drug dealer who gets a little bit of heroin or fentanyl and wants to turn it into more product. So this is their little bit of drug they got in the middle. And this is cutting agent over here. So they add the two together, they put it in their bullet blender, they think they're doing a really good job, but unfortunately it's not a smoothie, because it's gonna look like this at the end. So fentanyl has specific properties that require it to be heated a specific way in order to be distributed evenly in whatever it's being made into. This is only really achieved in the scientific lab, not going to be achieved in a clandestine lab in Mexico. So, or in someone's bullet blender. So they mix it up, this is what it looks like, so they start pressing pills out of it, or bags of heroin that are supposed to be look like heroin, okay? So the person that gets that one is pretty unhappy, the person that gets that one's unhappy as well. This person is feeling okay, decent high, this person has the perfect high, and then anybody gets a pill from this area here is gonna be a fatal overdose. So I was explaining to them, I go, has anybody ever heard of Russian roulette before? A few kids raised their hands, so I explained, anybody that doesn't know, okay, it's Russian roulette is taking a revolver, opening the cylinder, taking out all the bullets, putting one in, spinning it, closing it up, and putting it to head and pulling the trigger. And that's what I explained to these kids, that's what they're doing every time they take one of these pills. If it's not in a prescription bottle with your name on it, that you picked up from the pharmacy after the doctor called it in for you, you should not be taking the pill. The pills are prescribed. People typically don't give away their prescriptions, so this slide typically sticks in their mind with what they're doing. It's a little over dramatic, but that's really what it is. You're taking a chance. So it might not be the first, second, third, or fourth time, or the fifth time, but the 6 chambers in there. So it's gonna be on the 6th time then. It's just a matter of time. It's not, might not resonate with you guys, video games, but it's not, there's no redo, there's no reset, there's no over. It's like, that's it. Our life is very finite. So once they do this, it's like there's no coming back. So you guys can see for yourselves, these are real pills versus authentic pills. I'm sorry, fake pills versus authentic pills. I just said real versus authentic, okay? Authentic versus fake. The fake pills almost look better than the real ones do. When I was still on the street about 10 years ago, when the pressed pills started coming around, you could tell right away. Things weren't crisp, you could tell. Now it's, the fake looks just as good, if not better than the real ones do. And obviously this whole pill thing was a perfect storm because of the pill mills back in the late 2000s, they started clamping down on prescription, opioid prescriptions, so high demand and low supply. So the cartels, the Sinaloa and the Jalisco cartels, they fed that demand. Xanax is probably one of the biggest problems we have. Xanax is not an opioid, but the big problem with all the pills actually is that, specifically with students, I mean, it's not really just students, because I do think it's everybody. They don't look at it as drugs. It's just a pill. I'm not smoking crack, I'm not snorting coke, I'm not shooting heroin, I'm not smoking meth, it's not Molly or ecstasy, it's just a pill, it's a prescription pill. Yeah, my friend gave it, yeah, give me one of hers, or his. No, they don't, people don't give away their prescriptions. It's gonna be fake. So okay, yes, if it is a legitimate pill, all right, it is just a pill, but it has to be in your bottle with your name on it that the doctor called in for you. Then it's just a pill that you're supposed to take. But when it's one of these pills, there's lethal drugs in it. So it's the mentality that it's not, I'm not doing an illicit drug, but you are, unknowingly, but, and we also see Adderall. So now when it comes to, I showed you before and after pictures earlier, when it comes to fentanyl, there are no after pictures. So these are scholars and athletes, valedictorians, salutatorians, regular kids, regular students, professional athletes, Olympic athletes, collegiate athletes. None of these people were addicts. Maybe casual users having fun at a party, trying something for the first time. None of them were addicts. A few of the slides look a little different. The last chart I showed you guys had like a blue background, said Actus on it. So it was founded by someone called Michael Gray. This is his daughter. She had some mental issues. She was away at college and her prescription ran out, and she had an episode. So she went to the street to get something to calm her down. And they said that Emmy told her father that there was enough fentanyl in it that as soon as it hit her bloodstream, she was dead in a matter of seconds, as soon as the pill was in her bloodstream. So all of these kids, this foundation, the Actus Foundation, I think has about 25,000 strong. So all those people that lost a loved one to that was not an addict. And I said earlier that Xanax is one of the largest problems we have. So I've been dealing with this for probably the last 2 years. Had some meetings the end of 2021, the first week of 2022. We responded to a fatal overdose in Oyster Bay. It was a 20-year-old. I always ask everybody, anybody ever heard of, when I go to high school, has anybody ever heard of Shanghai? It's the top Catholic school in Long Island. Okay, well, We had a 20-year-old Chaminade graduate, died last January. Was not an addict. We were able to get into his phone. We saw communications between him and his friend, fellow 20-year-old Chaminade graduate. Okay. His friend, we went and spoke to him. He gave up the dealer, so we called the dealer out. We arrested the dealer. But the friend had bought 5 Xanax. He kept 3, and he gave 2 to the kid that died. The simple math, that's 40%. So he had 3, the friend had 2, he took them and he died. But it's the number one problem we have. These kids weren't addicts. They were bored. They were looking to have fun. You know, I know that there are a lot of mental health issues, and a lot of people turn to drugs because of mental issues. But kids nowadays, especially with COVID, like they're bored. They're looking for something to do. So they're going out there and they're just experimenting. And it's a shame, but it's starting at a very, very young age, and it gets worse in high school, and it gets even worse in college.
I mean, Matt, it's not a rationalization, but there is a tremendous amount of anxiety, and kids do sell their pills. They sell their prescription of Xanax and Adderall for a profit. You know, even a prescription, because I've had that experience.
They do, but
They do.
that they're in the minority.
Right.
Most
Well, I'm
pills
getting
we're coming across.
But then it creates a situation of dependency, or a situation where I need more. So all I'm getting at is that it leads to what you're talking about, but I'm just saying it can start as an innocent as, you know, Joe's selling half his prescription, and then that's not.
We arrested someone last week that was selling their own pills just
Yeah.
to make a little bit. They weren't even taking them anymore. They were selling them to make a little bit of money.
Right, but all I'm getting at is to some degree of the Xanax pop is not about recreation, it is about anxiety, and it is about not admitting to having that anxiety and going through these alternative sources.
But this is what I'm talking about, that it
Yeah.
really comes down to education and awareness. Like, if you feel you need that, go see a doctor and
Right.
get a prescription for it. Because if you go to the street, putting the gun to your head and pulling the trigger, and it's only a matter of time before you get the bullet. That's the point I try to get across to these kids, and I have no problems. Listen, if you need a prescription, I think you should be able to get it, like, legally. But going to the street it's a deadly option, because I see it every day.
All I'm getting at is in your presentation is expressing to parents that it's not just about recreational use. It's acknowledging that their kids might have a problem beyond that.
Okay, absolutely,
Yeah.
without a doubt. I mean, but
Is there a track, like in Nassau County, like what percentage is intentional and what percentage is accidental death?
I don't have
You
that.
don't know? Okay. Because at one point there was a presenter who presented that if you die of a drug overdose, it's counted in Nassau County as accidental, and so we don't really have an accurate death
Well,
by suicide.
There's a difference. There's definitely a difference when you go to someone's house and they have multiple empty pill bottles there, and there's a note, and that's a suicide. You know, that person intentionally, either whether successfully or not, tried to kill themselves.
Mhm.
So most overdoses are not intentional. I mean, if you're talking about prescription overdoses, I mean, that's on the low end. I don't really even, I mean, me specifically, I don't really count. If someone has fentanyl, like, oh, there are some Xanax pills, I don't count it as a prescription overdose. That's a fentanyl overdose. That is not a prescription pill overdose. It's not, because I actually, we you know, we have an analyst that does this stuff, and I told him, I said, we need to reclassify these, because, you know, when we get the drug test back, I go, and there's no alprazolam in their system. I said, but there's fentanyl. I said, it's not a prescription overdose. It's an illicit drug overdose. It's a fentanyl overdose. So more often than not, I would say they are accidental. Like that slide I showed you, these preventable, it's someone's taking one thing, they think it's this, but there's fentanyl in it. So, or even cocaine, they're cocaine, yes, okay. You take enough cocaine, it could cause a heart attack. I go, but it's not going to cause an overdose where you're going to stop breathing and labor breathing, and so, but we're finding cocaine with fentanyl in it. So it's everywhere, it's in everything. Just 1 minute. So last week there was an accident on the Southern State. Person was on drugs, state trooper responded, and the state trooper overdosed. Because the airbags deployed, it spread the powder, and the trooper had to be revived. The trooper had to be issued Narcan, and then he overdosed again, and had to be given more Narcan. 5 days ago, there were 11 officers on a search warrant that were treated for fentanyl inhalation. They were all, multiple officers overdosed in New Jersey. So it's not just a danger to the people that are actually using the drugs. You could be driving around and someone gets high and they crash into you and kill you. Or you could get exposed to the powder unknowingly. You know, it's everywhere and it's virtually in everything. There have even been a few documented cases where it's mixed in with marijuana. It's scary. That's why I try to be as real as I possibly can about it. Like, I know the problem's not going away. That's why I think that education and awareness is the number one most important thing, where I think we need to be putting our efforts so that these kids are aware of what is really out there, and just stem it's really, it's the only way that we can just stop people from coming, like stop our youth from getting involved in drugs at all, you know? So, you know.
I have so many questions, but I know you're going to finish your presentation?
Yeah, if I can, I just have a couple more slides. It's really geared towards the kids anyway, but we'll talk about Narcan. Has anybody ever had Narcan training?
Yes.
Okay, they usually do it for an hour. It really takes like 5 minutes. I was at one, and a doctor from Northwell got up, and it's very simple, and I explain it to the kids because I'm literally running out of time in my presentation when I get to this. So I always have my little bag with me with Narcan, and it's the foil pack. You open it up, you put it in the person's nostril, you depress it, and that's it. It's very simple. If it doesn't work, do the other one. And the good thing about it is, if you're at a party and you think someone's overdosed, and you hit them with the Narcan, you happen to have Narcan, you take it out, you use it, but they were just drunk, it cannot hurt them. It's only an opioid receptor blocker, that's all it does. They usually get, I know there are medical professionals here, so I'm sure you guys are aware way it works, but with opioids, let's just say this is the door of your opioid receptor. So someone's on an opioid, it closes the door, it slams it shut. So some are pretty powerful. Imagine you're trying to open the door, and I'm on the other side closing it shut. You gonna be able to open it? Probably not. So sometimes these opioids are too powerful for the Narcan to even break through. But the Narcan's job is to get in there and basically chop that receptor open so that the opioid can't get in. And then I talk about some of you guys were talking about the mobile crisis earlier, and people are like, oh, who's heard of this? Oh, I never even heard of it before. I'll have a room of 250 kids, and I'll say, who's heard of the Good Samaritan law before? And like 10 kids will raise their hand. A lot of people don't even know about the Good Samaritan law. And there's a law like this in virtually every state. Protects you from calling 911 because I guess states were tired and hospitals were tired of dead bodies being dropped off in front, because everybody freaks out and they don't know what to do. So they clean up and then they drop the person at the hospital. So this is enticing people to call 911. It protects them as long as they have less than A1 felony weight narcotics. They cannot, well, a couple other things, they don't have a warrant, they're not the ones selling, but it entices people to call 911. And that's really my presentation, so questions? Yeah.
Thank you.
Great presentation. Really understanding what the drugs do and stuff like that. You can scare kids straight by seeing those pictures and stuff like that. But my emphasis is that's kind of all results. So what's being done, I know education is important, to talk about why kids are doing the drugs. What kind of socioeconomic, psychosocial stuff, to talk about that before they even start. Why are we doing this? My mother beat me, something like that. And going to elementary schools and start talking about, their psychosocial behavior and stuff like that. I know you're at the point where, okay, I don't know why, but they're doing it. So there's got to be like a cart before the horse or whatever. I don't know if that's a question. The other thing I want to know, are there different drug in different communities? So say fentanyl is affluent communities in the suburbs and what's happening in, say, Wyandanch or something like that. Are there differences? You see use of fentanyl in one and something else in another, or what?
Okay. So historically, yes. Crack would typically be found in African American communities. Heroin would be found in Caucasian communities. Typical. Fentanyl, so I typically speak at schools. So I always, right before I speak, I always look up how many fatal overdoses and how many non-fatal overdoses have occurred in that community, and I share that with them. And I always make it a point when I get to the Nassau County slide, I said, you know, I go with the national numbers and then I go with the local numbers, and I say, you know, New York State's not immune, Nassau County's not immune, and the community we're in is not immune. You know, people die left and right. So when it comes to fentanyl, I always ask, I said, has anybody heard of discrimination? Right? And, I'm sorry, has anybody heard demographics? You know, I asked all the kids, I said, okay, all the girls raise your hand. Okay, half the room raises their hand. Okay, it's demographic. Sex, race, religion, all these things are demographic. And then, okay, discrimination. Who's heard of discrimination? Okay, taking one of those demographics and usually singling them out for something negative reason. Okay, these drugs don't do that. They don't care about demographics. They don't care about discrimination. They don't discriminate. They will kill everyone equally. So while they may be different drugs, they all have fentanyl in it. So now we had 3 fatal overdoses this weekend. Okay, let's just say there's been weekends where we've had 4. So like, there'll be a 58-year-old woman in Woodmere, a 22-year-old guy in Hicksville, a 30-year-old guy in Massapequa, and a 60-year-old man up in Great Neck. Pills, cocaine, heroin, whatever, they all have fentanyl in it. So it's, while they may be different classes of drugs, it all has, fentanyl has changed the game. So what, like I said, historically, like, you know, crack would be, you know, historically, but now it's just changed things dramatically where it's found in every drug. So it really, it doesn't make a difference. It doesn't make a difference if it's cocaine or heroin, because it all has fentanyl in it. So it doesn't matter.
That's every community. Every community.
It doesn't, and I always say, it doesn't matter if you're black or white or Asian, rich, poor, it doesn't matter. It doesn't matter your religion, it doesn't matter anything. Because you could live in Hicksville or Hewlett or Hempstead, it doesn't matter. People, it's killing everybody. Everybody.
Is there a reason why people are buying street drugs rather than prescription? Is it because, is the 6-year-old guy in Great Neck, I hate to be stereotyping, but is that person buying it because it's cheaper? Or you don't go into that? I'm not being critical, I'm just asking, you know, like, what do you see?
Well, we can't really get into the why after they've died.
No,
you know, like,
the obvious, you're telling me it's obvious when somebody is a substance abuser because the room is filled with, you know, pill vials or what have you. So is that person, I'm just, you know, again, as John is saying, if we look to why people are doing this, why is this takeoff? Clearly it's in everything, clearly it's more available than ever, but why is somebody taking that street drug, which is so questionable?
For the high.
Who's a 6-year-old
I think
person?
part of it, they don't even know any better.
Okay.
Or when it comes to kids, you know.
Kids are one thing, 60-year-old person is another, right?
Well, yeah. That might, listen, that maybe it wasn't caused by fentanyl. Maybe he took cocaine and his prescription pills, and the combination killed him. But typically, more often than not, 9 out of 10 people in the county that die, you know, from drugs has fentanyl in their system. So at some point, it plays a role. And then unfortunately, there are other drugs that are not classified as controlled substances, but have the same effect. And then there are other drugs there's one called xylazine. It's a tranquilizer.
Right.
They mix it with the fentanyl. So now it has the same effect as the fentanyl. It suppresses your respiratory system. I typically get into what happens with an overdose as well with the kids. But so the person has respiratory issues. Like first it goes into labored breathing, and then eventually they'll stop breathing. Okay, so you hit them with the Narcan. That's great. That counteracts the fentanyl. That counteracts the opioid. But the xylazine is suppressing the respiratory system too, so it will have no effect. So that's like intentionally killing people with mixing a tranquilizer with an opioid, because they're both going to suppress the respiratory system, but Narcan won't work on the tranquilizer.
Right.
You know, people always ask, oh, what about an AED? I go, it has nothing to do with the heart. Nothing. It's solely the respiratory system.
So now you were saying that kids, adults, whatever, that have mental health challenges may turn to drugs, right? Or for coping or whatever, like getting high. What is the,
I don't say that. I agree with it, but I don't think that every single person that turns to drugs has a mental problem. I don't.
Right.
I personally don't. I think some people are just bored and trying to have a good time and looking to have
so
fun.
my question is, how many people that start taking drugs turns into a mental issue, a psychosocial, bipolar or schizophrenia?
I can't answer that stuff. I don't know.
Because, I mean, that's significant, right? I mean, people that are taking drugs, their mind is being affected and could be being affected. Because it's not just they die or they stop and everything is cool. Because, right? I just have to talk to a doctor about that. But then I would think that if you're taking a drug, and you're quote unquote normal, and then all of a sudden you're acting.
Like I said, this wasn't my typical presentations. I'm typically talking to kids. So when it affects your brain, and I always say, okay, we all have normal brains in here. So when we go home and we smell the cookies, it releases dopamine. When we eat ice cream, it makes us feel good. It releases dopamine. Okay. Well, when you get hooked on these drugs, the only thing so this is what I skipped out. Why their faces look like that? Okay, because the only thing that they care about, the only thing that releases the dopamine is the drug. And if they don't get it, their mind is telling them that they're going to be in excruciating pain and or die. They probably will be in excruciating pain if they don't get it through withdrawals. But so their brains are rewired. They don't work like ours. So instead of saying, oh, I'm hungry, so I'm gonna go eat, they're like, I gotta go get the drug, or I'm gonna go break into this car and steal change so I can go buy more drugs. Or their brains they're rewired, and it takes. I don't even know if it can ever get rewired properly. I think back to a quote unquote normal brain, because that's the only thing. So they don't eat right. They don't sleep properly. They don't practice proper hygiene. Their teeth will start to rot. Like, these are the things. And honestly, with the kids and the girls, like that's what sticks out. I don't want that to happen to me.
Or they start hearing voices, or they start being.
But to say it does cause a mental problem because it rewires their brains. But that's not in my profession to help.
Just a quick question, this is a great information, I really appreciate this. Is Narcan easily accessible? Is that something that can go to the store?
They're giving it away.
Go to the county and get it?
Yeah.
I don't know if the county gives it away, but I mean.
Oh, they're totally giving it away. They're supplying high schools with it like crazy. So yes, it's accessible. It never used to be, but it's accessible.
You used to get you could get it at a pharmacy. You could pay for it. Someone was telling me now, like when they give out legitimate opioid prescriptions now, they have to issue a Narcan prescription as well.
Interesting.
Back in 2008, I used to be in Suffolk County, and at the time we were #1 in opioid overdose. I mean, the numbers would be off, but it was such a serious issue that, and this is different protocols for county. Only paramedics were able to set up the IV and push the medication. Once they introduced the nasal aerosol, it was amazing how much faster, two, how much higher the probability.
Yeah, but that was 2018. Okay, so they used to come. They used to have the bags. They would have 2 packs of 2 milligram doses, and then they did that for a short period of time. Then they upped it to 2 4 milligram doses because the drugs are getting stronger, and there are some times where multiple cops show up to a scene and they both use both of their Narcans. So 2 3 cops are there, so he had to get hit 6 times and come out, go back, come out, go back, because as fast as it works, it dissipates just as fast as the opioid could just close the door again. So and then it's not until they get the actual IV in that they're successful.
When I was in school, a big thing was Adderall to do well in tests.
Right.
So what's exactly is the danger of that kind of abuse of Adderall?
Well, Adderall is methamphetamine and amphetamine pills. We find that, we find them a lot. I think it's any drug that's popular, someone's going to press it into fake pills because someone might not be able to get a prescription. So we do find fake Adderall. We do.
I work with teenagers and older teenagers. One thing I found common between the 13-year-old and the 20-year-old was that it's not gonna happen to me.
100%. This is the problem with kids, is that they all think they're invincible. And I was there, I remember. I do, I know it was quite a while ago, but I remember. And that's why I put the gun up there. And that's why I put the game over up there, to try to put it into perspective for them. Like, there's no redo. It's not like 20 years ago where you could experiment, where if someone gave you a pill, like that's the pill. If it was a Xanax, it was a Xanax. If it was a Tylenol 3, it was a Tylenol 3. That's what it was. But nowadays, it's not like that, and it's just the problem has just gone up exponentially, you know. And you can't. Part of me feels bad for them. They can't even experiment with anything now because there could be fentanyl in it.
Everybody has a different opinion about the people coming in from South America and from Mexico. But I've heard some of the people saying that we're letting in all these people and they're bringing in fentanyl and creating this tremendous problem in the United States. So you're sort of substantiating that that's where it comes from.
It's 100% coming from Mexico.
I mean, with all the discussion about the yeses and the nos about letting in people from Mexico and all the other countries, why hasn't this been really mentioned? That one of the problems is how do we get drug people not to give people coming in, putting it on them or making it or whatever, and getting them into the United States? That seems like a bigger problem than just putting a lot of people in.
I agree, but that's on a federal level. And someone asked something like that to me once before. You know, what are we doing to stop the flow of drugs into the country? I'm like, we're Nassau County Police Department. We can't stop the flow of drugs into the country.
No, except that now there's everything is public opinion, and some people thought it was good to let people in, but when you bring out that it's bringing in fentanyl, that's another facet.
Well, those people may be bringing it in, but let's put things into perspective. Okay, so you have a tractor trailer that's seized at the border, okay, coming up from Mexico, and it's got 1,000 kilos of cocaine in it, or fentanyl, whatever it is. Okay, that's a write-off. That's a business write-off for them, and it's a huge win for the country. It's all smoke and mirrors. That's the tip of the iceberg. There were 20 other trucks that got through. They wanted that one to get caught. You know, they seize 1,000 kilos at the border. It seems great. It makes the news. It makes headlines. But like 10, 15, 20 other trucks got through that day. It's a business write-off for them. It's nothing. The problem's not going away. There's too much money in it, and there are too many people that are addicted in this country, unfortunately.
So it's not the huge numbers of people coming in.
I can't answer that for you, but the slide I showed earlier with the table full of heroin and the 1 kilo of fentanyl, someone could hop across the border with that in their backpack or even in a cargo pocket. Much more easier to transport because you only have to bring one. You don't have to bring 50. You only have to bring one. It's scary stuff. I always tell the kids, I apologize, it's not a rainbows and unicorns lecture, but it's just trying to open people's eyes to it, you know, especially the kids. I've been arresting people my entire career, and it's part of my job, and I enjoy doing it. And some were good people, and some were not so good people. But that does not solve the problem. We cannot arrest our way out of the problem. We can't.
Back in the day, it was marijuana laced with PCP, right?
Yeah.
And so it wasn't necessarily causing addiction, but it was definitely causing psychosis. You know, this fentanyl thing seems like it's causing that. You know, and either way, it's bad stuff. It's highly addictive. Wow.
And they're mixing it in with everything, so, you know, you get your cocaine from him. Now he starts mixing in fentanyl into it, or you try from another guy and there's a little bit of fentanyl in it. It's gonna be the best high you ever had. You're gonna get your cocaine from that guy from now on. So that's what, you know, and unfortunately, I know it's counterintuitive, but that drug dealers don't want to kill their clients, their customer base, but it's a calling card. Yo, where do you get his stuff from? Because they're all looking for that high. So they want to go to the same guy that person got dealt the fatal dose. They want it. It's like a business. It's a calling card for them. It's scary. But again, their brains don't work like our brains do. Any normal person would be like, whoa, I would never do that. But they're like, no, that's the guy we want to find. Like the girl I told earlier that nearly died and went looking for the same bag again. Had she not been saved, she'd be dead, you know?
I'm curious, so now that Mexico is manufacturing, do they need the source goods from China anymore, or are they producing that themselves?
I don't know.
Do you happen to know, with the legalization of marijuana in New York State, is the state requiring that they check the product to see if there's fentanyl?
That would be, I don't think so.
Really?
That's
It's like the
another
state
problem.
is just issuing for, license to sell, like a, alcohol license.
Oh, I would have thought that was the same place, okay.
But they're not checking product, like the state of New York doesn't open up every bottle.
There've only been a few documented cases, and they think that it was possibly, they might have just been tainted, not really done intentional, but you never know. There was a case, it's either happened in Connecticut, some people in Vermont were arrested, or people died in Vermont, people in Connecticut were arrested, I forget which way it was, but the family's like, they only ever smoked marijuana, Go. Something along the lines of marijuana fentanyl has to be put into it like PCP, like it has to be like infused with it. So sprinkling it on is not really gonna do it. So it's more likely like they took a Xanax too. So now there's fentanyl in the system, but they only smoked marijuana, and then took those Xanax that had fentanyl in them. So I've heard both sides of the story, that there have been cases and there haven't been cases. So there have been a few documented cases, whether or not they were legitimate or intentional. With cocaine, it's possible that they're just accidentally mixed, but I think they're definitely intentionally mixing cocaine, 100%.
Jennifer, you brought up the like Adderall and everything, and that was definitely, we used to call it the SAT drug when my kids were younger.
Yeah,
And-
or Ritalin.
Yeah, exactly. And now it's Xanax. Now Xanax is the high school drug. Kids are bent and filled with anxiety, whether it's, a valid or not. But that is the new popular.
But what it comes down to is that, again,
I know.
if it's
laced
not
with
a
fentanyl.
prescription pill
Yeah.
in the bottle with your name on it that came from the pharmacy that you picked up after the doctor called in for you, you should not be taking it. Don't take it. So Michael Gray says, part of his presentation, sort of a while ago, but they were grieving the loss of their daughter, and they were at the funeral, and one of his wife's friends offered her one of her Xanax.
I believe you. That's what I'm getting at, yeah.
It's like a cultural thing where people, pill pop. I understand people need it. It's also the most overprescribed drug that there is in the country.
Yes.
Xanax, 100%. But you had a question, yeah?
Yeah, when these kids take these drugs and you go there and you see they're possibly overdosing, is there some kind of rehab that they do afterwards to try to get them to rewire their brains?
Opioids are extremely addictive, and like I said, I'm not an addiction specialist by any means. As far as the police department, that's not something we can do. I mean, once we bring someone overdoses, we revive them, they're brought to the hospital. We will go and we'll interview them. I mean, we don't do that. We don't bring them to the hospital per se, like my detectives don't, but we will respond and we'll speak to them. We'll get whatever kind of information. But like I said, the vast majority of people are not cooperative with us. They don't, they're upset that we ruined their high. They don't want to give up their source. It's one of the, so the addiction, until these people hit like rock bottom and they're ready to move on with their lives, that where they come to an epiphany, where they decide they want to help, or, we've had people that sign up as a, informant because they want us to lock up with their drug dealers so they can't get their drugs anymore. Or we had another one that signed up that he was pissed that the guy put fentanyl, like maybe he does coke and the guy put fentanyl in it, or it was supposed to be, whatever it was, he nearly died. So he was pissed, so he signed up and helped us, make a few arrests.
You know, alcoholism is a disease, okay? And it's or people with alcohol problems are wired differently, where they have a physical addiction and a physical allergy if they pick up a drink. Now, with fentanyl, the drug users, you looking at a disease aspect of it, or that's the social workers to take care of? I'm not sure, but with, with alcoholism, it's not their fault they're an alcoholic, they're have an addictive personality, and their brain is wired a certain way. And I'm just thinking maybe it's also the same with a drug addict, it's just that they never, they look at it like, it's like a social thing back, like I'm older, so it's a social thing back in the 70s. But nowadays, like, did anybody check into that?
But into what?
Into like
The reason for the addiction.
Or disease, like it's not their fault that they're running to Xanax and running to get high.
Is it genetic?
Is it genetic?
We're talking about psychosocial issues that
Yeah,
go beyond.
it's not, the police department isn't looking into that.
Sorry, I mean, it's good to know that though.
Yeah.
No, I think people use drugs for all sorts of reasons.
Right.
But I can tell you this, if you pick up a bottle for the first time and have a couple drinks, you're not gonna be addicted to alcohol.
That's the
You're
huge
not.
difference.
Well, not necessarily.
Yeah, I can tell you this, but the first time, I mean, you're right, you're right, but
Only because I am one, I'll just admit I am. I'm an alcoholic in recovery for over 28 years.
congratulations.
Well, 14 because I had to get arrested in the middle, so that's another thing. I picked up a drink, I was immediately addicted.
Interesting.
Immediately. The fact is, I had one screwdriver. 2 months later, I went to the prom, I had a bottle of Matus. The whole night, I was outside looking for more alcohol. I couldn't even enjoy my prom. And I had only drank like maybe 3 times before that.
Alright. Listen, I think there are exceptions to everything, but when it comes to opioids, the first time you do it, it has its claws in you forever. And that's across everybody that uses them. Because, let's just take a kid who gets drunk for the first time, right? He's gonna feel real crappy the next day. He's gonna say, I'm never drinking again, which is a lie, because he probably will, he or she probably will, okay. I think we've all been there at some point. But with the drugs, with the withdrawals, their mind is telling them that, I mean, listen, I know there are links to addiction across, regardless of the substance, it has to do with, your personality, but, let's say a heroin user or a fentanyl user, their body is telling them they're going to die if they don't get the drug. So they will beg, borrow, and steal to get the drug.
And that's such a critical statement, as you said. Try it one time, and you can get, and that's something that has to be stressed with little kids. Don't try, just don't do it. Because once you do it, it's gonna be very hard for you to stop doing it.
And some people have asked, I'm like, I don't think that any person who's addicted ever wanted to be. I don't. Who wakes up one day and say, hey, I want to be addicted to drugs, or I want to be addicted to alcohol? I don't think anybody does,
Just say no.
But I also think that they just, we're all adults here. We think about the consequences of our actions. Kids don't. They're not, they all think they're invincible because their brains are growing for, a 17-year-old's brain's growing for another 10 years. Boy, I forget what it is, male, female, one's 25 and one's 27. Their brains are continuing to grow. So the early exposure to drugs, smoking, vaping, marijuana, all drinking, smoking, marijuana, vaping, all the earlier that they're exposed to that, or I should say, the longer you can push off your kids being exposed to that. I think it's something, statistically, it's 8% per year that it will push off any possible addiction later in life. But unfortunately, with the way things have changed with vaping and whatnot, it starts in middle school. I don't give my presentation to middle school kids. I have to really tone it down. But it starts at such an early age. My wife works in the middle school. Kids get caught vaping all the time. I mean, and to me, it's crazy.
Sixth grade?
And it's,
Sixth grade?
yeah, no, I know. Listen, I think we can all think back. They were all like, you know, the bad kids when there was always a group of, you know, all the you know, that were involved and whatnot. And listen, it is what it is. Every community has them. Every year, every group has them, and it is what it is. But it's just, I feel like there's more now, and it's you know, they don't think it's a problem. They don't think it's an issue. Vaping, you know, it's not a big deal. It's not cigarettes. It's not cigarettes. Come on, you know, it's just vaping.
What was the name of that website that you mentioned earlier where people share their?
Oh, the Addict's Diary.
Okay,
Yeah.
thank you.
Mhm. And there's also, just to, I mean, put it in with real stories. There's a 22-minute YouTube fentanyl documentary on YouTube. I always recommend that the schools show it to the kids before I come. It's a good precursor to me. It's pretty eye-opening. It's called Dead on Arrival. It's 22 minutes. It's really scary. Very real. It gives like 4 different families accounts of, you know, someone they lost to fentanyl. I mean, it starts off with like a 14-year-old. So it's very real. It's out there, and it affects everybody.
I said before that I work with middle school kids. Do you ever talk to parents? And the reason I'm talking is because we found, at least in the school I was in, a lot of kids who are on weed or worse would say, well, my parents do it. Why can't I? And we would bring that up at PTA meetings, and the parents would get very upset at us.
Yeah, I have spoken to parents. It's just not. I like to make the best use of my time. So when I contact the district or I'm in contact with the district, like, oh, we'd like to do something at night with the kids and the parents, I go, I'm not coming if 50 people are showing up. You know, when I go during the day, I hit every single student 9th through 12th grade. They can't get out of it. You know, and listen, I understand. You know, after school, you gotta make dinner, and there's dance, and there's sports, and there's religion, and there's all these things. So to get the parents back to the school, it's not easy. You know, I get it. I have 3 kids. You know, but I like to go to the schools and hit the schools just because I've been to tons of community meetings, and I go, you know, there's more people here than there typically are at a community meeting, and they don't want to talk. They don't want to hear what I have to say. They want to complain to the commanding officer about people running stop signs. So
It is amazing how many parents still in 2023 say it's not my kid. I mean, it just blows me away. But with David's point though, to the parents, is that with all due respect, you know, like you said, it's never going to happen to me, is prevalent of that immature brain of the 16-year-old. I'm never going to die. It's never going to, you know, it's not going to hit that point. And I can't tell you how many kids, parents, have found heroin in their little girl's pocketbook, you know, after a party, before a party. And it happens all the time now, obviously.
So the police department does Operation Natalie. That's one of the things we do which started, it's almost 10 years ago now, for Natalie Chiappa. She was the plain edge student that died. She was found face down on a couch while the homeowner was cleaning up around her, all the bottles and whatnot. So I actually didn't find out until last year that her parents knew that she was a heroin addict. They actually knew. But they didn't know that her boyfriend was a heroin dealer. They didn't know that the Amanda she was hanging out with wasn't the Amanda they knew, it was a different Amanda. So I always tell parents, I go, you know, when I was growing up, like, I have 2 older sisters, if you came to my house, like, you had to come in the house. You had, like, my dad had to lay eyes on you. I think some of these things have changed with social media. I mean, I'm very hard on my kids, personally. And I don't like to, like, lecture parents on how to parent, but, like, parenting isn't easy. It's not, but you have to parent. Like, you're not your kid's friend. You know, if you think you're being invasive in your kid's life, you're not being invasive enough. Do they pay for their phone, or you pay for their phone? Okay, look through their phone. It's not their private property. You know, take Snapchat for dummies. Okay, I don't know anything about it. Like, you know, educate yourselves. People sell drugs on Snapchat. They post about it. So I do speak differently to parents. I do, because I always say, don't be the not my kid parents. Please, please don't. Okay? Because I've arrested people and the parents come down like, that's not my kid. I go, this is them on the video. That's not my kid. Like hard evidence, and they cannot get it through their brains that it's their child, because that would never happen, you know? So, and the same, it'll never happen to me. The kids and the parents are the same way. Like we all like, oh, that's, won't be me, won't be me. Listen, everybody has to wake up and just be realistic about it. Okay? You know, I mean, we could all step out of here and get hit by a bus. It could happen. You know, you don't live your life like that, worrying about it. But you know, we have to be realistic about what's going on. And unfortunately, when I do speak to parents, there's just not that many there.
Yeah,
you know?
no, I get
So
it.
it's much. You know, some of the districts sent a letter home saying that, you know, they would be showing that video, maybe watch it with your kids before, or if you know, view it yourselves before, to look, you know, whether or not you want your child to see it, or other districts are like, hey, after I came, oh, please watch this video with your child. You know, some districts suggested that after, you know, the night that we do it during the day, to have a parent-student thing back again at night. And I'm like, you know, if there's 1,000 kids in the district and 50 show up, I'm like, it's not economical for me to come.
Yeah.
So it's like, for me to hit, you know, I mean, Sewanee, I mean, I've put down school districts that have 1,500 kids, and I mean, in high school in a day. And I mean, I'm reaching people. So I joke around with all the guys that work for me. I said, I do more to stop drugs than anybody else in this office does. I said, because you can lock as many drug dealers as you want. I go, the drug system can be out there. I said, but if I'm actually speaking to the students and then they never touch drugs, if I saved a life in that room, it's, you know.
True.
Absolutely.
Very true.
You have a counterpart in Queens and do you know him or her? Is there a difference, and I guess you don't have those statistics from Queens, but there's gotta be somebody like you from Queens, no?
Of course.
Do you know them?
I know the people that run the narcotics unit in Queens.
Cool.
John needs their name. We're gonna have them at a meeting in Queens.
We'll bring you to Queens.
What was your
All right.
name again?
Matt Landman.
Thank you.
Sure.
Thank you, Matt.
Thank
It's
you very
great.
much.
Equally as scary.